Churgai, and Choi. View. Admit.
Hello. Hold on, I should unmute. Can you hear me, pal?
I can hear you.
Hello, Sang.
Hi,
This is
how are you?
Andrew. Andrew Shriver. This is Sang Choi, the
Hello.
How are you?
Hey, Deb.
Good, how are you?
Good. So nice of you guys to join us. We're very, very grateful for you guys basically giving us the benefit of your knowledge. I guess that's the best way to say it. We're just thrilled that you're joining us. Thank you.
Thank you.
Yeah.
And Debbie, this is Andrew. Andrew Debbie, Churgai. Do I say that right? Churgai?
That is right.
Hey, such a lucky break.
A lot of people say Churgai, but that's not right. It's Churgai.
Good to know. Good to know. We'll
Now
make
I'm
sure
going to say
we'll make sure we
Churgai.
get that right.
You're going to jinx me. Deb, Andrew, did I share with you the big news? I did, didn't I, about the UN decision?
Yeah, that's exciting. I was actually going to say a couple of words about that. That's
Awesome.
really cool.
And Debbie, were you the
and then
author?
the House Rules Committee passed the MORE Act to move on to the committee. So
I thought that was
Wait.
okay, but the votes
I thought that
tomorrow?
was happening tomorrow. They voted on it today.
that's according to what I read. So.
Oh, I thought it was going to the House next week.
Oh, this is the Rules Committee.
No, it was supposed to happen today. Hold on, now we gotta do something. We have a press release about that.
Has a press release. So many emails.
So many emails. I know.
Well, you're about to get another one saying, with my 5 questions. Sorry, I forgot to get it to you today.
It says it's expected to be considered on the floor of the House of Representatives later this week.
Yeah, so
Oh,
that's tomorrow, right?
Hey, what's doing?
Mr. Holland, nice to see you.
Hey,
Yeah, good to
Dave,
see you.
how
How
are
are
ya?
you? Hold on one second. I got to get headphones in because I can't hear a damn thing there.
No problem.
Yeah, Sang and Debbie, you should know he's like our token techno. He's our token techno failure. This guy.
Oh, yeah. Listen, it's only because you don't know me well. You don't know my other failings. I've got a lot of them.
We only have an hour and a half, Dave.
All right,
Okay,
look
so
at the screen.
there we go.
Dave,
All
look at the
right.
screen and meet Debbie Churgai and Sang Choi. This is Dave Holland, guys.
Nice to meet you both. Thank
I
you
feel
so
like
much.
Have I met you before, Dave?
Deb, somewhere along the way, we definitely did. Back, and I want to say it was at a Cannabis Cup event, possibly. Way back when. Is that possible?
Maybe. There's so many events.
Exactly. Well, good to see you again, nonetheless. So, and Sang, thank you so much for being part of this whole thing tonight.
Thank you for having me.
Well, yeah, listen, I mean, this is like the cavalcade of stars, as they say on all the game shows. So we're ready.
I don't know about that.
Fake it till you make it. That's what it's all about, you know?
There you go.
That's right. That's right.
Inspirational, Dave.
I'll tell you. You know, we just kind of make it as we go along. But we've got really good turnout for this, Martha. Congratulations. And really,
listen, this is all due to our stellar panel, mister. Had nothing to do with me.
you know, however the magic happens, I'm grateful for it. So.
The proof is in the pudding. You guys are really, and it's because it's all female. You know, that's the secret sauce.
That is always the secret sauce. Says my wife.
So I forget now. So our presentations are 10 or 20 minutes long each.
I think we were shooting for 20, Deb, but if it needs to be 10, that'll work fine. No
But is
problem.
that including Q&A, or is the Q&A, or is there Q&A?
There is Q&A after you're finished.
Oh, okay.
And
okay.
you know, Deb, honestly, who is 6? Hold on a second.
No,
Sorry,
I can
guys.
talk forever, so.
Well, and we may pop in to sort of guide it from one to another if you're sort of wondering where to go with it. You know, I mean, it's sort of free form. And I think Martha had laid out a pretty good idea of how to get from one to another. And Andrew and I generally just sort of lead off. So we represent the two organizations. And, you know, we do a little introductory thing, and this will be the first thing since I think we had the election. So we'll just generally say, you know, there's a sweeping thing that leads us to today, which is with all the adult use that's coming into play, what is the future of medical, and why is it still important to pay attention to the medical, you know,
Woo.
situation?
Okay.
So that's
Okay.
your lead in, and Martha will run with it from there.
Andrew, June is saying she's waiting to be let in.
Oh, okay. Sorry. Let me,
Sweet
jump
June,
in.
in case you were admin, she says to me, because the other day I totally messed up on my Zoom, Andrew. You'd be mortified.
I see you. We should test out the screen sharing.
Okay, nobody talk about June anymore.
Hi, June. Nice to see you.
Hey, how are you guys?
Good to
Good.
see you,
June,
June.
you have my favorite Zoom backdrop with the skeleton always.
Oh, I know.
That's absolutely the best. And saying you
I
might be a
know.
close second with that awesome wallpaper.
Yeah, it's like trees. I'm in the forest, you know.
Why didn't we go with like cannabis stalks?
They are. No, I'm just kidding. I have no idea.
All right,
June,
I was just saying, and Debbie, that I'm just wrapping up, getting an email to you on the 5 questions in case we need time filler, but I doubt we will.
So can we try the screen sharing just so that we know it works?
Yeah, just give me 1 second. This is Andrew.
Okay.
All right.
So with the software we have, I think the only option I can make it work with is when you allow everybody to share simultaneously. Now that shouldn't present any issues, except that it does make us vulnerable to the extent that anybody would want to share their screen without our permission. That being said, we're actually very, we're careful about how we send out invites. It's only people who are RSVP. So, you know, it would only be in the unlikely event that somebody got hold of our Zoom link and wanted to make trouble. That happened to us once before. In that event, I would just stop, obviously, the share altogether. And if necessary, we'd cut out and then we'd jump back on. That's what we did. And it's happened once in our lifetime, and it was early in the Zoom days. So I know security's a lot better. Anyway, just wanted to flag that, you know, that issue, just as I would say a 3% possibility. So you guys are good with math, and I'm pretty confident it won't be an issue. Anyway, they don't want to.
It was a scarring experience for Andrew, so it will never happen again.
Well, it was scarring just in the sense that it really did actually, you know, it killed the mood, but we did actually recover, and it was really.
We did. I was going to say you're being too hard on yourself. We did
Oh, yeah,
recover,
yeah.
and you did beautifully with it, I thought.
So I'm gonna click that, and now go ahead and see if you can share.
Should I go first?
Sure. Perfect.
Okay.
Great.
Good. Fancy.
Oh.
Look at all the new logo.
Very fancy pants. June, how many years do you think you've been practicing cannabis medicine?
Oh, I don't want to age me.
Ah!
Do you see this?
Yes.
Okay, great.
That's amazing.
Wow. Cool. All right. And then is there one more? Debbie, did you have one?
Oh, yeah. So, okay. Yeah, I really messed up on this yesterday during my presentation. So, okay, share screen.
Dang, I feel like you can see all my wrinkles on Zoom.
You could say over 15 years.
Okay, I was gonna actually, you
That's what we
channeled
can-
me, June.
Yes,
You
is this
channeled
good?
me.
That's perfect.
Okay.
Great. All right, we're in good shape. Good. All right. Well, I'm gonna step away from the camera for just a minute, and and then at about 5:31 we'll start opening up the waiting room. There's a couple of people in there. We'll wait until there's at least I'd say 10 people. Either that or like 3 or 4 minutes, whatever comes first. Okay.
I'll be right back too.
All right.
I hear the news.
Yeah, that's me. Let me go turn that down, actually. Hold on 1 second.
This is what I mean. This is our technology guy.
Oh,
So
yeah.
when you ask people for GPS, or rather you ask for GPS directions from people, and Dave will be like, oh, no, never mind GPS. Take a left And then at the next light, you'll take a right. And I'm like, or you could give me the address and I'll just do it in the GPS.
There's a big tree.
Honestly.
That's how my
Oh, no,
mom
no,
does
you-
it.
your GPS
She's
won't
like,
get it right.
yeah, she's like, there's a big house that's pink. That's not it. You'll see another house with the red car. That's not it either.
Ignore
Just
that.
keep going.
And if you see the green car in the purple house driveway, you've gone way too far. You're gonna have to turn around.
June, your hair is so long.
I know, because I haven't cut it. I color it myself now because it's resorted to that.
Me too.
You guys look great. Most people don't look that great, frankly.
Oh,
do
thank
their
you.
own. Yeah.
I just want to say there's the peroxide in the toothpaste that's causing the graying right here. It has nothing to do with aging.
You're white. Yeah. You're bleaching.
That's right. I'm a two-tone kind of guy, you know.
It's a chic look, ombre.
Yeah, not many a man can sport that.
David, is Julie your sister or your cousin?
She's my cousin. She
She's
is
good.
my second cousin.
Got it. Okay.
Yeah.
Oh, okay. Julie
Yeah.
Holland. Okay.
Yeah. No, she's we are family is the song that gets played out there. But she and I really didn't meet each other until we both moved into the city. Well, she had been in the city longer, but I moved in the city in '94. We used to pal around quite a bit together, and just life takes you in different directions. But here we are in the same sort of space. It's kind of funny. But I remember her talking about some of these issues, particularly MDMA and things like that, way back in the '90s. I was like, lady, you're
Wow.
way ahead of the curve.
That's
Now it's catching up to her. So, who knows? Like, as she'd only given me stock tips back then, I'd be a lot happier now. Hey, Lizzie, how you doing?
I'm good. How are you all?
Good.
Doing good. Doing good.
Debbie, June, and Sang, meet Lizzie Shields, another co-founder and director.
Nice
Hi.
to meet you.
Nice
Nice.
to meet you.
I think we may have met. I don't know if we met at some of the early meetings, perhaps.
You know where you probably met in New York City at the launch, right?
Yep.
And then did you go to the Players Club or did you, Lizzie?
I missed that, sadly.
Uh-huh. That was fun. Those were the days
Next
when
time.
you could get together and have an actual have a drink.
I remember the one in New York at Comeback Daily was like people were clamoring for the last of the beers.
That's cool.
But we were pining for those days now, right? Oh my God.
know.
I'd clamor for a beer right now in a group setting. That close to people.
Go get one.
Yeah,
Yeah, it could be a party line,
I'm still on the clock.
I know working from home is a little slippery slope. I'm just.
I know. I had a couple of glasses of wine with dinner, so if my words slur, I don't know why.
It's just
You can loosen
that
up
delay in
for
the
that.
internet, that internet lag delay. That's what it is.
All right, listen, I'm going to start letting people to jump in here. I'm going to mute everybody for a minute and then
Hi, Sherry.
I'll mute as you go. So listen, are we all good? Everybody ready?
Yep.
Awesome. Well, thank you so much. I'm going to start letting people in. Here we go.
Deb, I think Americans for Safe Access is the only national patient advocacy.
Oh, yeah.
Right? Yeah.
It's the only group that really focuses on patients in the medical cannabis space.
Yeah. Yeah.
Nationally, yeah.
Might be back, might not.
Okay.
Okay. I'm hoping people out there nod if you can hear me. Yes? Good. All right, cool. Everyone's on mute now just because of the whole feedback thing. And so I know you'll all appreciate that. I'm going to start unmuting people who are going to be speaking with us. And we'll be starting in just a minute. So thank you all for joining us and for your patience. Okay. Where are you, Dave? Okay. Dave, you unmuted?
Yeah, I'm here.
Okay, great. Martha, you unmuted? Oh, no, try again.
Now I think I'm on.
I can hear you. Okay, cool. Let's see. Oops. Lizzie, can you hear us?
The other Liz. Hi, Liz. The other Liz.
Oh, is that Liz Walt?
I think it might be Liz Kramer Ernst at the bottom. Yeah.
Oh, sneaky. Here's the other Liz. All right, we'll have to figure that part out. Okay, good. Oh, wait, hang on. Let's see here. Sherry, can I hear you?
Yes, can you hear me?
Okay, yeah, I can hear you. Great.
Terrific.
Win-win. I'm just going to do a few more and then we will be ready. Okay, and I think our speakers are all unmuted. Is that right? Speakers, say hello. Okay.
Hello.
Four thumbs up. That's cool. All right, cool. All right, welcome everybody. I'll apologize as I keep staring to the side of my screen because I see that we have more people joining us as we go. So we're going to let a few more, well, we're going to let the rest of the people in the waiting room in, and then we will get started. So just thanks for your patience. Give us a couple more minutes.
Andrew, while we do that, a little logistics. You'll watch the chat, right, for the questions?
Yes, I will. And yes, we will definitely have a robust time for a question and answer session. And we invite people to join us for the chat. And yeah, be happy to do that. So it looks like we have somebody else coming in. Thanks again for your patience, everyone. We promise that you'll all get home on time. It's tough when everyone's on mute.
Keep practicing.
I'll be cutting you off.
We'll practice till we get it perfect. Okay, cool. Well, let's get started, and then we'll let a few more people in as we come. Thank you all for joining us to this another joint meeting of the New York City Cannabis Industry Association and the Hudson Valley Cannabis Industry Association. I'm Andrew Shriver. I'm president of the Hudson Valley Association and director of New York City. And I'm thrilled that you're all joining us. I want to just say a word about what we're trying to do. What we seek to accomplish is basically to be a hub for everybody who wants to be a participant in the industry from seed to sale. We want to make sure that we help get the market right. And we want to make sure that we advance policy that ensures that everybody has opportunity and access to all of the markets that will come into play, and that the markets that come into play do it in a way that is responsible to the needs of everybody, including the people who have been disproportionately impacted by the war on drugs. It goes without saying. We're making tremendous progress in the direction of full legalization, and that's exciting for a lot of reasons, both in terms of the marketplace as well as correcting all of those wrongs, and that's a long list. We ask people to join us, and that means to attend our events. We invite people to become members. You can join us at NYCCIA.org or HVCIA.org. You want to test us out a little bit, that's cool too. Just subscribe to our newsletter and mailer on the website, no pressure. We do ask that people be members in order to be part of our committees. And that's kind of a very cool thing, because committees are where we basically have the members help develop our policy. And by policy, that means every aspect of what we think a responsible market should look like, one that's responsible to the industry and to the community. And we feel that through dialogue, through our sort of tagline of join the conversation. We invite debate, we invite education, but it's always a conversation. It's a respectful back and forth until we sort of mold it into what we think we can all kind of agree on in terms of what's good policy. So that's what we do. And in doing so, we strengthen relationships. And that, of course, means that we can help each other grow as entrepreneurs, as business people. This is an extremely exciting time. We have a commitment from the Vice President-elect to start with decriminalization of cannabis on the national level. But beyond that, today, the Rules Committee in the House authorized the MORE Act to move on, which is very exciting. The MORE Act would allow not only for descheduling cannabis as a narcotic, but it would also involve expungement, which is, a giant leap in the right direction compared to where we've been. We have the fact that New Jersey has just legalized adult use cannabis, which leads to an almost inevitable conclusion that New York is next. And in that respect, the work that we do, I think, is more timely and relevant than ever. Also today, Martha alerted me to the fact that the United Nations had a historic decision issued, which is to remove cannabis from its illegal drug scheduling and to recognize it as a medicine, right? Round of applause or whatever we do on. But that just basically means that not only is New York ready, not only is our nation ready, but the world is ready. So, as associations that are dedicated to getting it right, this couldn't be a better time to be joining us and to be working with us. And in light of the UN's recognition of cannabis's medical value, finally, after it only took a couple of thousand years for the world to recognize it in some sort of formal way, but better late than never. Today is a great day to be joining us because we have a panel that's going to be talking about medical. And that runs from the gamut of what does cannabis do, how does it work, to what is the state of New York's medical market, what's it going to look like going forward. I'm absolutely thrilled to have the Powerhouse panel, and I'm going to let Martha in a minute introduce them. First, I want to turn the microphone proverbially over to Dave Holland, president of NYCCIA, to see if he has a couple of words. Dave, back to you.
Yeah, well, thank you. And I appreciate the opportunity to say hello to everybody here, because I too am excited, because for me, I've been around this for a fairly long time in terms of advocacy and fighting for the legalization issues. And we've seen now that what was once inconceivable in terms of legalization after the November elections is now the unstoppable, where we went 5 for 5 in various voter referendums. But the important thing is, while adult use is now something that seems to be a trend that is irreversible, so too is medical. And what does adult use do to medical is an important issue that gets overlooked all too frequently, because this was the one thing that has been so important to drive us to the point where we are today, is that it's taken the medical community to debunk those alleged scientific bases that were underlying the prohibition to begin with, and that this was an unsafe compound that shouldn't be messed with, to showing that there are 400 cannabinoids which have extraordinary value that has not even been untapped and revealed yet. And so medical is a driving force and should be something that ought to be looked to with great respect and great reception, rather than just using it as a gateway to, not that it's a gateway drug, but a gateway to adult use, because the two are very different. And I think that's what's so extraordinarily important about the future of where this goes with those communities that have built up around it. And there's no better people to learn from than this panel that has been assembled here today, and our friend Martha Mcdermott, who's going to guide us through a conversation to really learn about what is the cutting edge of medical and why it should continue to be a priority rather than deprioritized with the advent of adult use. So with that, thank you all for being part of this year. We will be putting together in very near future a medical advisory panel as well as a medical committee that will discuss these issues, because they are first and foremost in our thoughts, and they will not be superseded by other advent of voter referendum or what the MORE Act may bring to us tomorrow. My understanding is it goes to a floor vote in the House tomorrow. So while we eagerly anticipate that, let's embrace what we have today, because that's what brings us here tonight. So Martha, I turn it over to you.
Well, thank you, sir. What a wonderful introduction. These are going to be very hard, two voices, very hard to beat. But I'm really happy to be here with everybody tonight. First of all, I want to thank everybody for taking the time, because I know this is busy days and busy nights. And it's an important conversation, as Dave and Andrew started with. And I think it's so wonderful and so valuable. And to your point, David, I think maybe I'll actually start with an introduction of myself. I'm Martha Mcdermott. I'm the Director of Community Outreach and Patient Relations for ePain LLC. We're New York's only women-owned, family-run medical marijuana provider. And I come here tonight as a volunteer because I do feel I've been with the company for a little over 5 years now, since its inception, and I do feel so passionately about the cause and the issues around medical cannabis. I think it's, as to your point, David, it's often overlooked, and in my humble view on it, I think should be actually the underpinning of a recreational market, because to my understanding, statistics show and research shows unofficially that 50% or more of the recreational market, when they come to the market, are coming for medical reasons. So you'll ask a recreational user, oh, why do you prefer to use cannabis? And they'll say, oh, it really helps me to sleep, or it helps me to reduce anxiety, or it alleviates some depression, and it raises my mood. And they're not identifying as medical reasons, but those are, of course, very real medical reasons. So for all those reasons, I was very grateful when Andrew and David invited me to help to assemble this blue ribbon panel indeed, and to maybe look at putting a panel together, and even more directly coming up with a medical committee and advisory group that might put together some recommendations for our governor and our legislators. Of course, the national moments are very exciting, and the international ones. And for a moment, I'm going to highlight the fact that, yes, of course, Governor Cuomo has been very clear that he would very much like to pass cannabis this year with the Cannabis Regulation and Taxation Act, or we call it the CRTA, which he'll reintroduce. I guess it would be the third time now. He's going to reintroduce this January as part of his budget. And then if it doesn't pass in the budget, our legislators are likely going to introduce again the MRTA, which is their version of their bill, which is the Marijuana Regulation and Taxation Act. It's very likely that one of these two will pass because A, it's time, and the conversations have progressed, it seems, to a point where most people in government, from what I understand, believe it's highly likely. But secondly, the revenue issues, of course, are paramount. I mean, we're looking at, I think the last tally was $19 billion deficit after COVID calculations, or preliminary COVID calculations for cost. So for all those reasons, there's a lot to think about in New York State. And so I do hope everyone will listen to the panel tonight with an eye and an ear toward potentially joining us. Furthermore, because your voices, all of you in the medical profession who have come here tonight and scientific backgrounds, your voices for 5 years now, you've been accumulating knowledge, experience, anecdotal observation, perhaps, technical statistical research observation. That's very, very powerful and very, very helpful in the conversation with our leadership, because as most of you know, it's probably why you're here, misconception, misunderstanding, and stigma, unfortunately, has led the conversation for far too long, and by far too many people who have real positions of control and power and leadership. And we really need to help the greater population to understand that cannabis is, for the most part, a pretty benign substance, an organic plant that has a lot more going for it than against it. And so without further ado, I think I'd love to introduce our panel and get our conversation started. And just by way of expectation, to let everyone know, the way that we have outlined the evening is that our presenters will each speak individually on their particular expertise, and then we'll have a good, robust, and hearty question and answer time. So you can expect about a 15 to 20 minute presentation by each presenter, and then roughly a half an hour or longer Q&A. Okay, so, and now we'll begin first with introductions. Dr. Janella Chin. June, I can't, there we go. Can you give a wave? Thank you. Dr. Junella Chin is one of the most respected and experienced physicians in our state. We're very lucky to have her and her expertise to draw upon, and we're very lucky to have her tonight. Dr. Chin is an advocate for better understanding of the science and cannabinoid medicine. She's an integrative, right, June? Integrative cannabis physician. Her work has been featured in Forbes, LA Times, CNN, Good Morning America, and as a chronic pain survivor herself, she's dedicated her medical career to finding effective alternative approaches to patient care. June earned her BS from Cornell, her medical degree from Touro University, her medical acupuncture at Harvard, and was a researcher at Columbia University's Complementary and Alternative Medicine in Aging and Women's Health. The book she's co-authored, Cannabis and CBD for Health and Wellness, was published in June of 2019. June has been practicing cannabis medicine here in New York for the last 5 years. And prior to that, had a very lengthy practice in California. And so it's one of my favorite things in talking to June to get that contrast, understanding was sort of what it was like to run a practice in California and then come back east and do it here. And those are pretty dramatic differences in regulatory environments. So she's a wealth of knowledge there. And I'm always very grateful for her feedback on that. So why don't we do, rather than introducing everybody all at once, maybe we'll go one by one. And June, if you want to begin, June's presentation is going to focus mostly on the endocannabinoid system, the science and medicine of cannabis, and what it's like to be a physician in this space. Oh, I think June might be muted.
Thank you so much, Martha, for that introduction. I'm going to share my screen with everyone here. Can everyone see? Yeah. Great. So my story begins, I was a patient before I became a physician. At 15 years old, I was diagnosed with ankylosing spondylitis, which is an autoinflammatory disease of the spine. So basically my vertebrae fuse together. It feels like a bamboo stick, and spinal issues run in my family. So I have, we come from a long line of terrible backs. So by the time I got to med school in San Francisco, I had a really hard time standing. I was having a hard time doing rounds or even assisting in the OR. I would wear this back brace all the time. And one day, my attending, Dr. Levine, had asked me about it. And I explained to him that I had ankylosing spondylitis and I couldn't take medication while studying or while working in the hospital, obviously, because it made me very drowsy and foggy. And I was, I had the best pain specialist in town. I was prescribed gabapentin. When that didn't work, I was prescribed all sorts of antidepressants because, hey, if you're in pain, you're probably depressed. Cymbalta, Xanax, Wellbutrin. I was prescribed Oxy. And when that didn't work, I was on high-dose prednisone for many, many, many years. And I was really sad and disappointed because here I was training to be a physician. I was in a hospital surrounded by great medical minds, but no one could really help my chronic condition. And I really couldn't find any answers. So this was, the late 90s. So Dr. Levine pulled me aside and he handed me this bottle of tincture. Now he is an HIV and AIDS physician in San Francisco, and this is what his patients used. And he said, this is cannabis, but it won't make you high. And he didn't call it CBD at the oil at the time. He just said, it's a different type of cannabis plant. And I remembered it smelled awful. It smelled like wet grass and dog. And, I took it. It sat on my dresser probably for about 2 months before I decided to take it. But I knew that I was at a crossroads. If I didn't do something about my pain and inflammation, I would not become a physician. So what is the endocannabinoid system? And for God's sakes, why didn't I learn about it in medical school? California legalized cannabis in 1996, right? So over 20 years ago. And when I look, there's over 6,000 citations in PubMed. There's over 200 peer-reviewed studies. And if you look outside the US, over 20,000 journal citations. To understand how cannabis works in the body and the brain, you got to think about some of the systems in our bodies that we learned in science. Think about the digestive system, think about circulatory, our respiratory system, our nervous system. Well, the endocannabinoid system interfaces with all these other systems. There are cannabinoid receptors distributed throughout the brain. So if you look at here, everything lit up in red, you'll see the cannabinoid receptors exist virtually in every brain region. It's the largest receptor system in the brain. And if you look at this PET scan, everything you see here lit up represents the galaxy of endocannabinoid receptors in the body, right? So they blanket the entire body. So one of the questions I'm asked in almost every office visit is, how addicting is cannabis? Now, this is a graph from the National Institute of Drug Abuse on the dependence rate of substances. So you can see here, tobacco, 32% at the top, alcohol 15, and then you have cannabis and caffeine on the bottom at 9%. So although cannabis can be addictive, I do treat patients with cannabis use disorder. So I don't want to mislead you here. But what's interesting is as cannabis use goes up in states that pass medical cannabis laws, the dependence rate among those cannabis users do not differ between states with or without medical cannabis laws. So to just give you some perspective, doctors, especially during the pandemic, are doling out Xanax and Klonopin like candy. That's a 44% dependence rate. If you take it for more than 2 weeks, you can get really, really hooked on it. And then there's device addiction. So that's a dependency rate of over 70%. So it's quite of a difference when you look at coffee and cannabis on the bottom. So what about our skin? Did you know that our skin has its own endocannabinoid system? The skin's ECS creates a very delicate balance of skin homeostasis. It regulates cell growth, moisture production, even immune protection. So if there's an imbalance in our skin's ECS, you will find patients with acne, psoriasis, allergic dermatitis, even hair growth disorders. So researchers are exploring skin CBD formulations to increase the activity of the skin's ECS and to treat these inflammatory disorders. So for all of you with a science background, just bear with me. The CB receptor is the most abundant G protein coupled receptor in the brain. And GPCRs are like an inbox to our neurons. They move information from the inside to the outside of the cell. GPCRs are involved in every important physiological process, from our immune system, even the way we taste and we smell our food. So GPCRs are so important. They're the target of over 40% of our pharmaceutical drugs. So stuff that you have in your medicine chest, triptans for migraine, you might have a beta blocker for hypertension, albuterol for asthma, Tagamet, Zantac for stomach ulcers, even fentanyl and oxy for pain. These all target GPCRs. So since CB1 receptors are the most common GPCRs in the brain, and you forget about cannabis for a moment, I don't understand why we don't teach medical students about the most abundant receptor in the brain. So if we take the time out to uncover some of these scientific facts, we can make sense of this on a biochemical level, right? We can start to connect these dots. This is why cannabis works so well for a variety of symptoms. You have chronic pain, then you have appetite, insomnia, anxiety, PTSD. So phytocannabinoids, coming from the cannabis plant, is very, very complex. There's over 100 unique chemical compounds, over 1,500 chemical variants. And all these compounds work together to create an entourage effect. They enhance and they balance each other out. But it's not just about CBD and THC anymore. It's about minor cannabinoids. There's over 100 cannabinoids identified and still more being discovered. Places like NYU Langone, Montefiore, GW Pharmaceuticals, they have active clinical trials researching the effects of CBDV on autism. The Montefiore study is funded in part by the Department of Defense. So in our clinics, we are collecting every piece of patient information and integrative cannabis use that in our medical charts. So as Martha had mentioned, I owned and operated 3 integrative clinics in California, and now I have clinics in New York and Connecticut, and we treat children and adults. Now the richness of our data, not to mention the sheer volume, it's a bottomless well of cannabinoid therapeutic data. Some of the questions that I ask is, which cannabis formulations do patients prefer? What type of delivery methods? How often are they using it? What times of the day are they using it? Our cannabis patients monitor their real-time health. We put in all the data from, the parents' seizure journals. They keep track of their child's behavior, the eating and sleeping patterns, their IEP, how cannabis changes their PT and speech. What about certain cannabis products? Why do they work well for women and not men? Menopausal women, there are certain types of cannabis plants that actually increase hot flashes. What were their estrogen and progesterone levels when they felt cannabis didn't work at all? So I'm really looking at cannabis usage, adjusted to age, to gender, to weight, to physical activity. I'm looking at genetic tests, blood tests, microbiome, dietary restrictions, allergies, health records. So we're getting data from patients over 100 times a year. And all that data we receive, we're able to port back on advising them what to buy or even help manufacturers make better products. We understand a huge amount about our patients because the patients are telling us not only about their cannabis usage, but they're telling us about their lives. So when we match these data sets together, who else might need it? I take these insights to different companies, not only suppliers and dispensaries of cannabis industry, but to companies that specialize in dietary supplements. I'm working in medical education. I'm taking part in clinical trials, even luxury lifestyle cannabis brands. I work with cannabis companies in the digital health space. Now, we are looking at pharmacogenetics, so medications with cannabis. Now, pharmacogenetics is a study of how genes impact whether I need a high dose, a low dose, or maybe a different medication altogether. Cannabis medicine, maybe plus your statin, plus your blood pressure meds, or even your ADD meds or antidepressant, all these medications interact with each other. So we're combining the power of data integration and diagnostic insight. So when your body's disturbed by a disease, for example, or maybe you have a genetic mutation or an environmental factor, this affects your metabolic profile. And these biomarkers can help us understand disease, toxicity, drug interactions, and other factors. So we have all these amazing technologies now, and we can integrate it, we can leverage it. So I think this approach really can catalyze and foster true health, the future of health in medicine, which includes cannabinoid medicine. So cannabis is unique, right? There's no precedent, no other drug in the world that we're using recreationally and medicinally. So patients really have to demand that their health practitioners get educated. It's our responsibility. It's really our responsibility to be capable of engaging in meaningful discussions with patients regarding science, the potential risks, and the potential benefits of cannabis. So as Martha mentioned, I co-authored this book with Elisa Sherman, and this book gives you a comprehensive overview of all things cannabis, so you can understand how it works and how to use it. But at the heart of this book, as women authors and as cannabis users, our empathy and our intuition, determination to really take charge of our own health really defines this book. Thank you so much for listening.
Sorry, everybody, for my little Zoom snafu. June, I wanted to thank you. What I was saying was that I just love your presentation. And I often say this, and I really mean it. I've seen June's presentation before. It's brand new every time. For example, June, I didn't realize that you're working with research and working with other medications and working together in the research. And I find that to be the most fascinating and interesting piece of all, because what I hear from patients, and I'm sure Sang will echo this in our next presentation, people are often talking about wanting to get off of opioids for pain control and pain management, sometimes wanting to do the blend, asking a lot of very deep and interesting questions around, how the two interact, what that is like, what's recommended, what's not recommended. It's quite surprising to most people that there are very few, if any, counterindications with cannabis. Is that right? Oh, sorry. Yeah, there you go. Now she needs to be unmuted again, Andrew.
You went mute.
There you go. No, there's a lot of drug-drug interactions, but it really depends on the patient. Like, for example, I have a lot of chemo patients that if they're on a steroid and they take cannabis close to when they take their steroid, they can have adverse effects and they think it's the cannabis, but it's the actually taking them together. So if you space it apart, you actually can avoid, adverse reactions that happen by combining the two. So these are questions and these are conversations that need to be had at the doctor's office.
Okay, perfect. Okay, great. All right, well, thanks, June. Okay, our next presenter is my dear friend and colleague, Sang Choi. She is the head pharmacist for the downstate region and the dispensary manager for our New York City location, located in 2nd and 3rd Avenue. Sang has almost, I think we determined today, 21 years of pharmacy experience in retail, varying from HIV and infectious disease, oncology, compounding, and fertility experience. So Sang comes to, and by the way, of course, have I started by saying she's a pharmacist? That would be an important point. And for those of you who maybe don't appreciate it, in New York State, the regulation and the law demands that dispensaries are run and operated by pharmacists, which separates us from the rest of the country. I do believe we're the only state that requires it. Other states sometimes will have dispensaries, and certainly their medical portions run by medical professionals. But I know when I first came to Etain, it was a real eye-opener for me to speak with Sang and our other pharmacists and to learn the breadth and the depth of the training that pharmacists undergo. I don't know that people really truly appreciate the 5 years of in-depth. It's everything from biology and organic chemistry to anatomy and even counseling, which as a social worker, I was fascinated. Half of their curriculum is mostly what I did in social work school. So pharmacists come to the table really roundly experienced and educated, and that's something I think people fail to appreciate until, of course, they have the moment where they sit down with Sang and they get their consultation. So as I was saying, to wrap up her introduction, through her extensive experience, I want to go back and say she received her degree from Long Island University College of Pharmacy and served as a pharmacist in charge and manager of a specialty pharmacy consulting patients with complex drug regimens prior to coming to us at Etain. Through her extensive experience as a pharmacist, Sang brings strong competencies, and I can attest to that. As a pharmacy manager and patient counselor to Etain, she really prides herself on her ability to interact with patients and really believes in the importance of high quality medicine and committed to counseling in providing compassionate care. And as Sang is the first person our patients will come across, that last bit cannot be understated. And in fact, in a fun, very relaxed moment recently, Sang and I sat down and calculated the number of consultations she does roughly per day, then averaged it per week, then looked at it per month, times the 5.5 years she's been with us at Etain. And we determined that Sang has delivered over 15,000 consultations. So she's deeply experienced. I'm very happy to present Sang, who now will talk about the medical applications, meaning the different ways you can take medical cannabis, as well as the New York State program itself operates. Thanks, Sang.
Hi, everyone. Thank you, Martha, for that introduction. So I'm just going to start by sharing my screen. I don't have a whole lot of slides, but I thought we'd just kind of talk about it as well. So. Okay. Okay, the Compassionate Care Act launched in January of 2016. It was actually signed by Governor Cuomo 18 months prior, but it took some time to write up the regulations and things like that. So just wanted to give you some numbers. To date, we have 3,080 registered practitioners, and the practitioners that are able to certify for medical marijuana in New York are physician's assistants, doctors, and nurse practitioners. And to date, the registered number of patients we have are 132,000 approximately. So these are the qualifying conditions that you need to have to be able to get a medical marijuana card. It can be, one or more of these conditions. So we have cancer, HIV/AIDS, ALS, Parkinson's, MS, spinal cord injury with spasticity, epilepsy, inflammatory bowel disease, neuropathy, Huntington's disease, PTSD, chronic pain, and opioid substance abuse disorder. In addition to having the qualifying condition, you also need to have a secondary qualifying condition. So let's say you've had cancer, but you don't have any symptoms or you're not in pain, you don't qualify for medical marijuana, unfortunately. So it has to be accompanied by cachexia or wasting syndrome, severe chronic pain, severe nausea, seizures, severe or persistent muscle spasms, PTSD, and opioid use disorder. So I just thought this would be very similar to what Dr. Chin put up. I thought it was very interesting. So you can see all the annual deaths from the different substances or things. So if you look at marijuana, it's 0, and it's actually safer than peanuts. So this is what a sample certification looks like. A lot of times the patients will actually bring in the certificate. A lot of times you can also find this at the dispensaries online. So either way, we're able to, find sort of what the doctor has recommended or, the practitioner has recommended. So you'll see that right here. It's, the qualifying condition. So the doctor's name or the practitioner's name, the patient's name, qualifying condition, secondary qualifying condition. And over here on the right is just what the doctor or the practitioner recommends for the patient. A lot of times I would say the practitioner leaves it up to us at the dispensary to counsel the patients, talk about the different products that we have, different ratios, and, basically talking about the condition that brought them in here. And we just talk about the little things that may be bothering the patient, how we might be able to help with the different products. And in order to come into a dispensary or to purchase product, you have to get a medical marijuana card. So patients and caregivers with a valid New York MMJ registry card, photo ID, and a certification come into our dispensaries and purchase medical marijuana. So this is our product list. So we have 4 different ratios. So we have Dolce, which is our 1-to-20 high CBD product. So as Dr. Chin spoke about before, it is about the entourage effect. So having CBD as the primary sort of cannabinoid and adding a little bit of THC does help the CBD to work a little bit better. And I guess that's sort of the difference between hemp and medical marijuana or cannabis. And it's, it's not just about the THC and CBD, but all the other, components of the plant. So you're talking about terpenes and the other, components. So we have Dolce, which is our 1-to-20 high CBD. So this is non-psychoactive. The question I get the most is, or, comments that I get, the first thing before they even sit down to have an actual conversation, the first thing is, I don't want to get high. So that's the first thing I hear. So then just kind of explaining, what THC and CBD, what they do, it kind of gives the patient a better understanding that, it is a medical effect, and that they will become a little bit more tolerant to the products as they use it. And it's not different than any other medication that they take. If they were prescribed a prescription from a doctor or, a practitioner, I feel like a lot of people would take it without, without any questions. Oh, my doctor prescribed it to me, so I have to take it. But cannabis is very different because of all the stigma and, the previous experiences that maybe someone has had. So we have Dolce, which works as more of an anti-inflammatory, anti-anxiety, muscle relaxant, just gives you a nice relaxation effect, but doesn't really give you the psychoactivity or the high. Mezzo is our next ratio, which is 2-to-1 CBD to THC. So it's 2 parts of CBD to 1 part THC. The other thing that we do know about putting CBD and THC into a formulation together is that CBD will mitigate some of the side effects of THC. So Mezzo, because it's a little bit higher on the CBD content, it'll bring down some of the psychoactivity or some of the side effects of THC. So great for, pain, inflammation, maybe inflammation with some neuropathy, which THC is really amazing for. So this could be used maybe during the day. Then you have Balance, which is a combination of THC and CBD, but they're in equal amounts. So this ratio is one of my favorites, especially if a patient is coming in for the first time. haven't ever used cannabis as medicine, or it's been like 50 years. So this is a really nice, for me, a nice gauge for a patient to start with. And because it has equal combinations, patient will say, it helped me with my inflammation, but it didn't really help me with neuropathy, or something to that extent. So we kind of know what cannabinoid is doing what at that point, and then we know how to adjust it maybe the second time they come back. And then you have Forte, which is our 20-to-1 ratio of high THC. So this one I recommend for, of course, pain. Great for nausea, great for appetite stimulation, great for patients going through chemotherapy when there is lack of appetite, nothing tastes good. Also really great for sleep. So these products are probably Forte would be more nighttime usage. Balance could be night or day, just depending. So the way they come is we have a lot of different products. So we have vaporizers, which are great because they're very fast acting. So if you were in a painful situation, or if you were nauseous, it'd be really great because it would work so quickly, and it subsides. It's about, hopefully it subsides in about 5 to 10 minutes. Also, the duration is very short. So if you needed something, but you need to go do something later on in the day, you know how to gauge that time. Then we have the sublingual products, which last about 4 to 6 hours. They go right underneath the tongue. So we have the tinctures and we have the oral sprays. You just spray it in your mouth, and the other one, you just put it right under the tongue. We have water-soluble powders, which are really great too, very versatile. You mix that into anything you drink. So it can be coffee, water, tea, smoothies, soups, anything like that. And it would last about 6 to 8 hours. So nice duration. You can kind of, if you had it in water, you can sort of sip it throughout the day if you'd like. We have capsules, which take the longest to work, probably about an hour to 2 hours, but also gives you about 6 to 8 hour duration. Maybe great for nighttime if you're having trouble sleeping. And then we have topicals that you put onto areas that you have pain. And we have just, we're not allowed to have edibles in New York State. So we do offer, these honey lozenges, which we get pretty good feedback. It's like organic honey. So that's really nice to just be able to carry it around whenever you need it. So I thought this would be an interesting slide as well. So these are all the dispensaries. So if you look, all the dots represent a dispensary, and a state this size, we don't have many, but New York State is, very highly regulated. So you'll notice that, there are a lot of multi-state operators here in New York, and you see that Etain is still independent, a women-owned company. So that's it's a pretty nice slide there. And this is projected sales for the New York medical marijuana program market. So you can see all the years on the bottom there, and it's somewhere between 60 to 70 million for 2020, and jumping to 80 to 90 million in 2024. Okay. So those are my slides. So I don't know if you have any questions for me.
Well, first of all, saying that was brilliant. I've never seen the slide, and I'm fascinated. I might even ask you to go back on the states, the multi-state operators, and all where everybody is located. I didn't appreciate it. It does seem a little bit clustered. I don't know.
Yeah. Well, there's a bunch in like New York City, so.
Yeah, heavily weighted downstate. We might expect that. Yeah, right.
So there are 10 companies right now in the state of New York. Each one has 4 dispensaries and a grow facility. So it's a vertically integrated program. So you have to have 4 dispensaries plus a grow facility where you manufacture all the products. The thing that I did want to touch upon is the controversy with the vaporizers. So the vaporizers, a couple of months back, there was a lot of, problems with it, causing people a lot of health issues. So just wanted to tell you that in the state of New York, it's such a highly regulated program that everything is tested. A sample lot sample of your lot is tested by the Department of Health. So, they test for potency, tests for contaminants, fungus, bacteria and pesticides. So the New York, the vaporizers have never, we have to date not know anyone who's actually had harmful effects from actually using the New York State vaporizers.
And Sang, I'm sorry if I missed it, forgive me. Did you talk about ground flower in the earlier time?
Oh yeah, so no, I did not. So thank you for reminding me. So we do have ground flower for vaporization. So it is not to be smoked in the state of New York. It is for vaporization only. So you just put it in a vaporizer, it just kind of heats it up to a certain temperature and you're inhaling the vapor. It's very much like the oil, but just different, obviously, because it's the whole plant. So you're getting the oil vapes, the extracts, you're getting, it's very clean in the sense that all the other things from the plant, like the fats and the waxes, have been taken out of it. So you're getting a very pure product when it comes to the oil vapes versus, the flower. But of course, certain people are used to using certain products a certain way. So I think that's why the ground flower is very appealing.
And later, I'm hoping that all three panelists might talk a little bit about applications and people's favorite, what your observations are in terms of patients favoring certain applications over others, and whether certain conditions maybe respond better to certain applications. We might talk about that in a bit. But saying one more point that I thought worth noting as well, and you touched on it just now. New York is so very highly regulated. Arguably the most regulated of all 35 medical states and the 14 or 15 rec states that exist. And one thing that I know I hear a lot about from patients is a frustration around pricing. Could you maybe talk about that for a minute? Because it is significantly different. For example, if a person's used to the legacy market, they'll come to our product and see an extraordinary leap. And maybe is there a few things you could say about that?
Oh, well, I think when we first started, the prices were very high, but over time we have been able to lower our prices. So I would say, a large vaporizer, is about $90, about 500 milligrams of THC. I don't know how much it costs, on the gray market or in other states, maybe $50 or something like that. So, yeah, we continually try to lower our, pricing and things like that. But at the same time, we do offer, if you have Medicaid or Medicare, we do offer a discount there. And, we'll have sales and things like that. But yeah, it is probably more expensive than other states.
Okay, thank you so much. What a great presentation, as always. I really appreciate it. I know our attendees do as well. And that will bring us to our last panelist, last but certainly anything but least, Debbie Churgai. Debbie is my newest friend in this experience, and I'm so happy because for me, I came to Americans for Safe Access has been a patient advocacy group, in a national patient advocacy group for many, many more years than I became aware of them. But my introduction was when, in the most recent version of a report that they've issued for, I think, going on 10 years now, the State of the States, which I highly recommend anybody who might be interested in looking at. It's an incredible overview of each state and their medical programs and where they stand and where sort of the specifics are with logistics on things. It's an exceedingly interesting overview and very easy to read. So that comes out of Americans for Safe Access and provides a very nice launching pad to introduce to you the executive director of the program, Debbie Churgai. We were saying earlier, Americans for Safe Access is the only patient advocacy group that's devoted for medical marijuana patients and therapeutic treatment and research in the United States. And that's quite significant considering, to June's point, that in 1996, California legalized medical marijuana. And to Andrew's earlier point, cannabis has been used as medicine since the first historical indications date back to 3000 BC in Mongolia, China. So to think that it's taken all this time, and there's only one national group, really tells us that they're a high quality, hardworking group, and we're very, very lucky to have them. And I know today has been a very exciting day for Debbie, and I'm sure she'll talk about that in her talk. She is the executive, Debbie Churgai is the executive director of Americans for Safe Access, a medical cannabis patient advocacy nonprofit whose mission is to ensure safe and legal access to cannabis for therapeutic use and research. Debbie oversees all organizational and program operations in regard to education, training, policy, research, product safety, and business compliance. One of Americans for Safe Access's best or well-known sections for focus would be on their educational programming. And that was another area that when I did some deep dive research, I was very impressed by. They offer a number of different patient support and education programs. One is called the Patient Focused Certification, and the other the Cannabis Care Certification. And as the name suggests, one might be better, more indicated for those who work within the industry working with patients, and the other the Patient Focused Certification, which is directed more to givers and patients, advising them on how cannabis works as medicine. She serves as a writer and final editor on all of American for Safe Access publications, including the State of the States report, the Patient's Guide to CBD, and the Medical Cannabis Access for Pain Treatment report. Her previous work experience was in the behavioral and public health sectors, working on projects in tobacco regulation and substance abuse prevention and treatment. She holds a master's degree in psychology. So without further ado, take it away, Deb.
Thank you, Martha. I first want to ask how many people from the people I can see have heard about Americans for Safe Access before today? Okay, a few of you, that's good. I always like to ask that question first because I think it's really important if you have been in the cannabis space or industry that you understand the advocacy and the history of how cannabis first became illegal and why it's so important to change that. So I myself am not a patient, which I think surprises a lot of people. And when I became the executive director of the National Organization of Patients to represent medical cannabis, I remember thinking that I maybe shouldn't because I'm not a patient. But what I think is really important about that is that it just shows you do not have to be a patient to believe that cannabis is medicine. You don't even have to utilize it yourself to believe that it is medicine. You don't have to even know someone who uses it to believe that it is medicine. It's really important just to understand how cannabis works in the body. I think if you're in the industry, it's also really important to know the science about it. So I love the presentations that Dr. Chin gave and Choi gave that were just so educational. And I feel like everyone in the industry should be giving those type of presentations so that they can understand the different methodologies of cannabis, how to use it, and the science behind it. But also, the advocacy is really important. So what I'm going to talk about today a little bit is about, I'm going to give like a national perspective of medical cannabis, but also talk about what happens when legalization comes into a state, what happens to the medical cannabis program, and why we should be keeping patients the priority. I think legalization is great, but what I'm going to show you in this presentation today is that, unfortunately, legalization is not the answer to everything. And there's a lot of barriers to access that I'm going to talk about today that legalization, unfortunately, won't fix. So let me just share my screen. Can everyone see that okay?
Mm-hmm.
So right now, I call this harmonizing and unifying regulations in the US because right now we have state by state regulations that are different. As Martha mentioned, we do this state of states report, which I am going to talk about. And we analyze the states on over 87 different factors. And all these states are different in all these different factors. So we at Americans for Safe Activists are trying to find a way where we can harmonize these regulations and kind of build a federal oversight of medical cannabis. As Martha mentioned, ASA was founded in 2002, so we've been around for a long time. So if you are unfamiliar with us, please become familiar with us, especially our website. safeaccessnow.org has so much, so many resources on it, so many educational materials. We have our State of the States report, Patient's Guide to CBD, Patient's Guide to Medical Cannabis. We have all the laws in every single state. We just have resource after resource after resource, all free. Everything is free to download because we're a patient organization and we don't want patients to have to pay for anything because they already have to pay for their medicine. So please, please visit our website. And I think you will be amazed of how much information is on there. As some of the things we do is legislative work. We have chapters all over the country because it's really important for legislators to hear from their actual constituents. So we really like to get chapters throughout the country to represent their states. We work with industry professionals. We try to help with educating them, training them, and we try to help educate patients, because the more that patients, the more that medical professionals, the more the industry are educated about cannabis, the greater potential for the program. So here it is, the State of the States report. This is actually the sixth year that we've done it, I think, maybe seventh. And this year, was a doozy. I think it was like 187 pages. As you can see, we do a report card for every single state. And that's states that have full medical cannabis programs, states that have medical and legalization, states that just have CBD, which are those yellow states there, and then states that have nothing. And of course, states that have nothing all have Fs. States that just have CBD or low THC also all have Fs. We grade them on A to Fs. And that just shows you right there how the states that are just CBD or low THC are really not providing for patients. So this is a great report for you to download on our website, and definitely encourage you to read it. Anytime I'm doing a presentation about a specific state, because it's kind of hard to keep everything in track about every state, I always go to this report first, do a quick lookup of the summary. I remember right after we did this report, which is just a few months ago, my brain was like full of information about every single state. I could have answered any question you had, but now it's been a few months now. I've lost a lot of that information, but it's really interesting, I will tell you that. So 4.4 million medical cannabis patients across the United States right now. That number fluctuates, 4.4 to 5 million, I've heard. It's hard sometimes to calculate. We did just try to, right before the State of the States report, and we came up with about 4.4 million. California is the tricky one, but we won't talk about that. But what's interesting to know is last year's report, it was only 3 million patients. So over 1.4 million patients in just the last year alone. And that right there shows you the growth of medical. This is medical cannabis patients, not adult use patients, but these are all registered medical cannabis patients. So if you think about adult use market, which is also, as we know, utilizes, patients utilize the adult use market, the amount of patients is growing exponentially. And what I also want to mention when we talk about adult use versus medical, a lot of people think that the adult use market will far exceed the medical, which is not true. If you think about it, patients need this medicine. A lot of them need it every day. A lot of them need it every day for the rest of their lives. A lot of them need it large amounts. That little 10% THC that a lot of states cap doesn't help patients that really, really need it. So with doctor education, with patient organizations coming on board, the number of patients is going to grow so high that the adult use market is not even going to compare to the medical market. Trust me when I say this. Like, so you, I mean, it's really frustrating when I think people put a focus on the adult use market, because the medical market really has a much bigger growth, because we have so many doctors that aren't on board. We have so many doctors that don't even recommend, that don't want to recommend. The stigma is still there. Patients don't want to ask their doctors. Doctors don't want to talk to their patients. These are all things that we are working on. We are trying to help the industry grow by growing your customers. So the work that we do is really important. We wouldn't have 4.4 million patients, honestly, if it wasn't for Americans for Safe Access and the education that we provide. Right now, there's a war on drugs. There's a war on the poor. There's this outdated definitions of medicine. These are the issues that we're dealing with right now. And what I mean by the war on the poor is that there are so many people that can't afford this medicine. And does anybody actually think of them? We kind of joke that if we're creating a market for a bunch of wealthy people, yay, we've won, right? But that's not true. We have so many people that could utilize this medicine, could save their lives, but they can't afford it. As an advocate, unfortunately, a lot of my job is getting phone calls from patients across the country that can't afford this medicine, that can't access it, depending on what state they're in or what condition they have, or where they live, where they work. And it's sad. I get a lot of sad phone calls. It's a hard job. So this is what, really gets me going and keeps me working towards this. So it's really important, not just to applaud the access that we do have, but to understand the lack of access that still exists in our country, which I will show you in this presentation. I'm going to give you a case example from Michigan of the lack of access. So first, I just want to show you. So today, as Martha said, I have exciting news. Today, the United Nations declassified cannabis from the most restrictive category. So they have an opposite category. Their category 4 is the most restrictive. Ours is, in the United States, it's Schedule 1 is the most restrictive. So unfortunately, the United States did not declassify. Only the United Nations made a suggestion to reclassify. This puts a lot of pressure on the United States. So we're excited about this, but cautiously optimistic. We have been working also internationally for a long time. So we were excited to see that the work we've been doing for years finally came through today with international classification. It's really amazing, huge news. And so if you haven't heard about it before today, I'm excited to tell you this because it really is exciting. As you can see, this map shows there are 44 countries with access to medical cannabis at the federal level. United States is not one of them. So if you could look, the purple is medical cannabis is legal at the federal level. Look at all those countries that have it, and yet the United States does not. It's just crazy. So as I mentioned, Michigan. Now, why is federal oversight of cannabis important? Well, let me tell you. So this is Michigan. This is a State of the States report. They actually did really great. They have medical and legalization. They did great. They have a B+. If you can see the scores on the left, they're pretty high. So you think, Michigan, you're lucky to be in Michigan. You got great access, no issues, right? Well, the truth is that there are so many barriers that are still affect access. Living in poverty alone, this is just Michigan. Over 1.5 million people cannot afford their medicine. Serving probation, you're not allowed to access medicine, 55,000. Living in hospice, residing in assisted living establishments, patient treatment centers, federal employees, veterans, elderly, homebound, employees that are drug tested, organ transplant list. That's the one that gets me the most because I've actually had calls from people who are on the organ transplant list who get kicked off because they are a legal medical cannabis patient in their state. So depending on what state you are, I'm sorry, I don't know what it is in New York, but depending on what state you are, if you are on the organ transplant list, you can get kicked off for utilizing medical cannabis, even legally, even if you're a legal patient. So we've had patients have to move to different states just so they can be in less pain and still be on the organ transplant list. I had a call from an 18-year-old college kid one day he lived in Florida, and he called to see if we knew anybody that we can connect him to in California, because he was moving there because he was getting kicked off the organ transplant list. So it's things like that that we see as advocates that make this a really important for us to work on all these issues. And these are all issues that we are trying to work on. So of the 15 states and DC who have all developed medical and adult use programs, all of them still have outstanding work related to extending adequate patient legal protections. So as I mentioned, like there's arrest protections, affirmative legal defense, employer discrimination protections. I did see that New York, I think it was Andrew or David had mentioned that New York has something in their regulations that where you can't discriminate against patients in a work environment, which I think is great. Not every state has that. Housing protections, legal issues, the loss of parental rights. Parents are still losing their children for being legal medical cannabis patients. It's still happening. Organ transplants, reciprocity between states, and protections from DUI. So these are all issues that are still in these states that offer medical and legal. So there's still problems that we need to work on. We need to work on these patient protections. We really need to work on these patient protections before we get all excited about the adult use market. So here's the New York. If you guys were wondering, our State of the States report, New York got a C+, which is, you know, but where New York really, and you guys know this, where New York really had the problem on was the access to medicine, because not only New York has very few dispensaries compared to the amount of patients. Look at this right here, ratio of patients to retail, 3,100, is that right? There are states that have like 58 patients to like California, I think was like the lowest, 58 patients to retail locations. So New York, yeah, it has a lot of issues that still need to be fixed. We still need to fix this. And the vertical integration, that is something that I don't understand, quite frankly. I don't understand why there is a requirement for vertical integration. There's only a few states that do that. We try to advocate against it. The other thing is delivery. New York does not have delivery, is that right? And that is a huge problem for access, especially homebound patients. There are many patients that are homebound that can't leave their houses. Please let me know if my time's up. So how does New York stack up? Like I mentioned, on parental rights and civil protections. New York still needs to improve these. They need to improve the organ transplant status, the DUI charges for patients, and reciprocity.
You're doing great on time, by the way.
Okay, thanks. Ease of navigation.
Oh, Deb, one more piece. I'm sorry, before I hate to interrupt you, but quickly, New York does have delivery now.
Oh, they do. Okay. Woo. Okay, good. Good, because New York needs it. We kind of use Maine as an example here because for one of the things is New York has the qualifying condition list. And I saw someone asked a question about, has there been other conditions added, which is a great question. On our website, we have this amazing list of every state and their qualifying condition list. And it is like giant because as you can imagine, every state has different qualifying conditions. And the way they word the qualifying condition is also different. So you can have like pain management, pain assessment, all these different words. what we believe is there shouldn't be any qualifying condition list. We believe that a doctor should be able to recommend cannabis for any patient that they think could utilize it. Access to medicine. This is where the vertical integration comes in as a real barrier to access, especially within the industry, especially if you're trying to work in the industry or you're trying to get a license. It's extra hard because you have to not just know how to run a dispensary, you have to know how to run a cultivation and manufacturer. And I'm not really sure why those need to be vertically integrated. And also the cap on the number of licenses awarded is really low in New York compared to other states. And home cultivation is another issue, which would really help. Functionality.
You were going to get to that. That's a big one, I know, for people. Cultivation.
Oh yeah,
is a big one. And then we have. I'm sorry, I should probably have said about 5 minutes.
Okay. I'm almost done.
Yeah,
cultivation.
Enjoying this. This is amazing. Amazing.
Home cultivation is really important, and people always kind of feel weird about that. But honestly, it's the best way to save money for patients who can't afford it. If you can't afford it, but you can grow it, and just for yourself, not to sell to other people, then it's a great way to provide medicine. Especially, I know a lot of parents or caregivers that would love to grow their own medicine and use a specific cultivar to grow it at home. It's really important for a lot of people. So functionality, let's get rid of the vertical integration. Consumer safety and provider requirements. This is huge. This is so different throughout the states. In fact, there's a picture of a label right here, which I love. This is a Maryland label, which is one of the best in the countries. Can you see everything that's on there?
Mm-hmm.
There are certain states that literally only have like THC on it. THC, CBD, and it doesn't have the percentages. Like there's no standardized requirements throughout the country. It's crazy. Sometimes they have terpenes, sometimes they don't. Sometimes they have percentages, sometimes they don't. Maryland actually complained because they had to write so much on their label that sometimes it takes over the package. But to a patient, this is so important. There are patients that are actually allergic to some of the terpenes. They can have adverse effects. So it's really important for patients to know this information. Yeah, not everyone needs to know it, but if you really want patients to come to your facility, you want to provide them with the most information as possible. I also recommend COAs if you have them, giving them COAs with information. So what ASA did to kind of try to figure out how we can fix this problem is we came up with a federal oversight of medical cannabis. It's called the Office of Medical Cannabis Control. We actually drafted this legislation. We're trying to find a legislator to sign on it now. All these offices and subdivisions, I don't have it in this presentation, but we actually have examples of what every single organization and department will be in charge of. We have a report on this on our website, and it talks all about the Office of Medical Cannabis, and it has the full draft legislation. So please feel free to read if you're interested, because especially with the Biden administration, this might be a really good time to talk about a federal oversight. And this is just a graphic that we did that talks about the agency roles post comprehensive legislation. So we don't just think about changing a law. We think about what's going to happen after the law changes, and we come up with a strategy. So the important thing about the OMCC, which everyone always wonders about, is what happens to the current license holders. Don't worry. In our legislation, all current license holders are grandfathered into the federal oversight. So don't worry about that. In dispensaries, cultivations, manufacturers, everything. And I think that's the most important. And federal licenses would be able to participate. Oops, sorry. In the research program. This slide, the only reason I have this slide up is because I want to show you that first thing right there where it says in-person issue visits from constituents. This is why advocacy is so important. because this is what we do. What we do is we take people, it used to be face-to-face, but now it's virtual. We take constituents from states, we have them do face-to-face or virtual meetings with their representatives, and we talk about why, cannabis is needed. And it's really important. Legislators don't just do things because it's the right thing to do, I'm sorry to say. They do it because their constituents wants them to do it and they want to get voted again. So it's really important for advocacy organizations like ours to do this work. We're starting a policy advisory committee this year. So anyone that's on this call that is interested in joining, please reach out to me. You'll be part of our advisory committee, and we'll talk about what we do policy-wise. You'll be able to help us, and what's important to you. If it's delivery or if it's home cultivation, we'll be able to work on those things that are important to you. So please contact me. This is my email. And just, thank you so much for listening.
Debbie, thank you. Debbie, thank you. I can't say enough times. Until this moment, I've never had such a comprehensive national overview presented, and the points that you raise are so important. And my big takeaway that I wrote in big bold letters, patient protection is critical for the regulations, so that patients don't get run over, so to speak. I mean, it's a bad analogy, but patients we have to build in those protections. And I think the other point that I loved you made, which is something I don't think people think about, medical patients are returning patients monthly. That is exactly right. And it's often overlooked. Where a recreational consumer is probably going to be more interested in trying lots of different things in lots of different places, and maybe coming back and maybe not, and having different influences. So I can't thank you enough for presenting tonight. And now I know everyone is so eager to get to the real meat and potatoes, which is the question and answers. I think the chat was veritably blowing up over there, right?
That is correct. So we, given the length of the chat, that teaches us that we should, never underestimate the level of involvement and great sort of like interaction. We're not gonna have time to get to every question, but this is why we keep the conversation going from point to point. And as we mentioned, we're talking about forming the medical committee. So people who are interested in learning about that, please, by all means, follow up with us at the info addresses, and then you all have access to. Actually, Martha, before we log off, please make sure we put into the chat just the website access for each of the speakers if you have it handy, not to give you too much homework. So I'm just going to pick a couple of questions, just kind of to try to cover at least various points in the chat. And some of them have actually already been answered, which is you can grow medical grade cannabis at home. I think I just heard that. That was Mike's question. There were a couple of specific questions for Dr. Chin about the impacts in terms of Lewy body dementia and lupus. Can you say just a few words about that? If I promise to unmute you, you should be able. There you go.
Yeah, so for Lewy body dementia, I do treat patients. It helps with the constant waking up in the middle of the night. So I find that patients with dementia, Lewy body dementia, or Alzheimer's, even Parkinson's, when they're getting up a lot in the middle of the night, getting up confused, of course, we have to be careful of polypharmacy. I make sure that I work with their team of physicians and making sure that everyone's on board. What's been very helpful actually during COVID is that everyone is on board with telemedicine now. So I'm actually able to Zoom in with other family members across the country and other specialists that might not have had time to conference in on a call. So their neurologists or their pain specialists can pop in a telehealth Zoom meeting so that we're all on the same page, and it really helps coordinate care. Great,
thank you. God, it's like you can just tap anywhere and great information just pops out. So thank you. The whole panel's that way. One of the questions that was asked is whether or not concentration formulations are derived from a single plant or across the spectrum. And that kind of ties into another point that somebody made about how strains are not identified necessarily in what's dispensed. Maybe let me tie those two questions together because people do kind of, they're in the adult use market strains have, a lot of significance, and how different strains are defined in terms of impact. So good questions. So formulations derived from a single plant across the spectrum, and what do we think about the idea that strains are not necessarily identified?
Yeah, I worked, because I was in California for so long. Strains was a really, good marketing tool, I think, for a lot of dispensaries. But it is just that. So in California, I've experimented with, Blue Dream from 4 different dispensaries, and it always gave different reactions to the same patient, because you really can't trust that they will label it correctly. Especially with California being the market that it started in. I think what's more importantly is the cannabinoid profile. When you really look under the hood and you're looking at the percentages of the cannabinoids, you're looking at the terpenes, I think are more important than just the names of the strains.
Yeah, I mean, Blue Dream grown in California and let's say Blue Dream grown in New York can have completely different profiles because it's a product of the environment that it's grown in. So it has so much to do with like the soil, if the soil is used, or the temperature, light, everything. So it can be a completely different plant from California, when it gets here. So yeah, strains it is a nice marketing tool, but I mean, Dr. Chin is correct. I think you really have to look at sort of the THC, CBD, the minor cannabinoids and terpene content. Because THC and CBD are always going to do what it's supposed to do. It is a compound that we know does certain things. So if we look at it from a medical or a therapeutic point of view, it's always going to do what it's supposed to do, which is to help you relax. It helps with pain. It helps with anxiety. Across the board, always going to do the same thing. It's pretty reliable, THC and CBD and the other cannabinoids.
So kind of interesting, in a sense that sort of busts a couple of not quite myths, but I guess there's a lot more emphasis on it than what it sounds like might be reliable, and that also goes to, I guess, one of our missions, which is making sure that we identify products correctly. It's a good point, great point, Debbie, about labeling. Really key and an important piece for what comes next. One question had been asked, but we're pretty sure that it had been answered by Deborah about, in THC products, how many milligrams of THC per dose? And we had, this just goes to the intellect of the group. Somebody answered it. So just double checking, I think this is right. It's 10 milligram per dose for THC is a maximum. Is that right?
In New York, yes.
New York, okay.
I think California too.
And in California. Yeah, I've actually heard that with a lot of states, that tends to be but of course, you can prescribe different dosages to your patients depending on,
Yeah, you could take 2 capsules, 3 capsules, but each dosage form can't be more than 10 milligrams of THC.
Right. Okay.
But I just want to say the one thing, the problem with that is, while legislators seem to think that's the best way to protect patients, a lot of patients actually need really high doses. So if you're eating an edible and you need 60 milligrams THC, you have to take 6 pieces of chocolate or 6 pieces of candy or what if you're a diabetic? So it's just those THC caps, while I understand while they're there, they don't really put patients in mind.
That's correct, Debbie. When I treat a lot of actually spinal injury patients, paraplegics, quadriplegics, they need really, really high doses, even my ALS patients. So they, unfortunately, they can't find it at the dispensary. So they do go to the illicit market and they're getting dabs and shatter and, resin where it could be more concentrated.
Well, I guess all the more reason, all great illustrations as to why regulation is actually, whether you are pro or con on cannabis, regulation just eliminates those issues. I guess I'm kind of preaching to the choir on this crowd, but probably worth it.
And Andrew, it keeps the dosage consistent as well. One of the things that I've realized in watching things and hearing what other feedback is from other states, the quality control and the quality assurance is actually really important to our patients. And they speak of it and they are relieved by it, because as they remind me in a very simple way of saying so, I go and I buy from the guy on the corner and I don't know what I'm getting. And so, I like that part about regulations. I'm not a big fan of rules always necessarily, but when it comes to medicine, regulations really, really are important. And I know Amy Peckham, who's our CEO, if I have gotten anything out of working at Etain, it is her emphasis on consumer safety. Very, very important to her. And I would argue for the entire industry in New York, even though when we began 5 years ago, I think there was a lot of grumbling about all the regulations. I think for the most part, people have come around and they see it for its strengths. I mean, it's not ideal. It's not an ideal situation. And like you say, we need our committee to really help to advocate. But, for the most part, I'm proud of the fact that we do keep our consumers safer than, sometimes you'll find friends of mine just came back with some product from Oregon. And it was like green slime goop and nobody really knew what was in it. And people were just like, okay, we'll just take a spoonful. And I stood there saying, I'm not so sure about that. That's not a great idea. And I kind of did a quick little patient education moment there. But, there was one question, if it's okay if I jump in with it, that I thought was a good one about the difference between a bud tender and a pharmacist. And I wondered if June and Sang could maybe comment on that for a minute.
Before we answer that, I just acknowledging people's time. I think people should feel free to stay on for a couple more minutes while we've got a few more questions. This is fascinating. I know a lot of people want to stick around, so I'm not going to be a slave to the clock. That being said, with a couple more minutes before 7, for those of you who do need to log off, I want to thank you for coming, and also just to ask you to log into our website and sign up for our e-blasts and newsletters. This way you'll see what comes next. We've already told you one of the things that's going to come next, so please look out for details about how we form our medical committee. We're going to have more discussions like these in addition to committee work that's ongoing with our regulatory committee. So we're going to have more announcements about that. Exciting stuff. And again, we invite you to join as members. That's sort of the ticket into the committee. We're going to get to not only be part of the conversation, but you get to be part of forming policy. So a little ad for that. In addition to the fact that I invite you all to please follow up with these speakers, who I'm sure can, provide you with more information and assistance, and you're clearly going to the top of the crop. So that being said, let's stick around for maybe a few more questions for those of you who'd like to. And let me, now that I broke the chain of thought, ask you guys to remember the question and go ahead and answer it.
The bud tender versus the pharmacist for June and Sang.
I mean, I went to pharmacy school, know some things about drugs and how they interact in your body. Maybe I have the medical jargon and, I know how to speak it. But I will say that getting into medical marijuana, I didn't know very much. So just like Dr. Chen said, they don't really teach this in medical school. They don't really teach this in pharmacy school either. So a lot of it was really just doing research on my own, going to conferences, reading. Just really educating myself. And I'll have to say that I've met a lot of great bud tenders too, who are super knowledgeable and know a lot of different things. So, I mean, I don't know. I just feel like we have we have the knowledge in the background as far as body functions and systems. But doesn't mean that bud tenders don't know what they're doing in other states.
Right. Fair analysis.
That's so nice thing. You got to give yourself more credit. I mean, pharmacists can do medical reconciliation. They can talk to patients and understand drug-drug interactions, understand anatomy, physiology, and biochemistry. I can't say the same for bud tenders. When I was in California, it was very difficult for me because I would, our office and I would have to be the go-between. So I would walk the patient, when you get to the dispensary, call us because I need to be there in the conversation between you and the bud tender so that he or she does not steer you in the wrong direction and hand you something with high THC. And I don't want my 92-year-old woman with Parkinson's having high THC. In New York, I sleep a lot better. I sleep so well because the pharmacists are at the dispensaries and we see everything in the prescription monitoring program. I know that they are asking wonderful questions and they are advocates for patients and for physicians as well and for nurse practitioners. So it's a big difference.
Oh, thank you, June.
And can I say one thing about that? If a bud tender says to you, this is how this makes me feel. That should never be said, because as you know, cannabis is individualized medicine. So unless you have my same condition or my same height, my same weight, it's going to affect you differently. So I really don't like it when bartenders, say, well, this is how it makes me feel, and say that to a patient, because it will affect them differently.
So I'm just going to suggest just two more things from the chat, and then, we'll end it. It's always good to leave a few questions unanswered. We'll bring you back. First, I did want to give a shout out to Colleen again for again giving us some more information. And I did not know this. This is interesting. New York prohibited the mentioning of any strain name, I guess, in the regulations for medical. I actually hadn't been aware of that. Do we know? Do we have any background as to why? And I'll be happy to unmute Colleen actually as the author of that. But I invite the panel to mention that. Is that because of the sort of stigma that goes with the culture that preceded this?
Hi guys. Yeah, that it is to prevent any kind of street name association. And largely when I spoke with Senator Savino and the departed Senator Larkin, when they were creating New York's program, they wanted vertical integration because they wanted overarching seed to sale control, monitoring, and upkeep of data across the board, so that they weren't you weren't going with a 3-tier system right out of the gate, because they wanted all this like pharmaceutical oversight. And so they wanted to go more on the pharmaceutical route versus what the California model. So they wanted to eliminate any sort of legacy market references. So putting a strain name, and like was mentioned before, growing conditions largely impact the way that a strain would be received and the effects for each person. So they just didn't want to put that in, and patients ask for it all the time. I feel like, it's a double-edged sword. It is medicine, but for people who are familiar with strains and are some more informed patients, being able to access a strain that they're already familiar with is important. And, going into a dispensary like Etain or, anywhere else and like asking, hey, what is in the Forte powder? What is in the Balance powder? Can you tell us what strain it is? We want to know, is it a sativa? Is it an indica? Is this something, if I take it at nighttime for bed, am I going to be up all night? So those kinds of things are important. But again, with the 10 milligram dose, it's kind of like, you got to try and see, because everything's new. These are all like new delivery methods for people. But this was a great panel and a great conversation. So thanks for putting this all together, you guys.
No, it's our pleasure. Thank you. I'll go to one last question, and then we'll kind of adjourn again, just out of respect for people's time. This is the kind of thing that could go on for hours, but we're not going to insist on that, certainly. From Melinda, any opinion on using Arfin Med as an EMR to document visits with medical marijuana patients? First, perhaps break that down for us, panel. Like, tell us, what that refers to, or we can ask Melinda to do that. Let's see, is Melinda here? Let me gonna unmute. Sorry to put you guys on the spot in these last couple of questions, but it'd be good to have a little clarification. It's interesting.
Yeah, and I couldn't quite hear. Was it Martha? What was it again, Andrew? Can you repeat?
Oh, it looks like the questioner might have jumped off, but the question was.
No, I'm here.
Oh, okay, go ahead. Yeah.
Yeah, so Arfin Med is a national electronic medical record that does target medical marijuana patients. And it actually has a whole platform, and on it, it does ask a whole bunch of questions about strains, which is why I asked the question about strains, because I have no idea about them, not ever having used it myself, of course, but having treated approximately 2 to 3 patients a week. So I find it very easy to use this EMR. It's specifically designed for medical marijuana patients and has a portal that has a follow-up format for them to check in with you, to record how they're feeling. So I've been using it and I really like it. So I just wondered if other people used it.
So what do we think, panel? Is this something we use? Is this something that sounds like
I have a question then, Doctor. If you're using it, then you're using another separate EMR for just your standard patients, or does it go on top of your current EMR?
Oh, sorry, let me just fix that. You should be unmuted or able to unmute. I'm sorry about that. Oh, there you are. Okay.
Oh, right. Well, I currently use it for all the patients. Because there's a choice of what your treatment is, cannabis or no. So I just choose no. I'm a pain management doctor anyway. But I find it really useful for the marijuana patients. It does ask a lot of questions that I haven't been, or does prompt you to ask them. Of the patient, the dispensary, the strain, the amounts, and all the different formulations, which I find helpful because we have a chat about all the different formulations and the follow-up with each one. So I have found it useful, and I just was curious if other practitioners were using something similar.
Yeah, I have not used it. I just don't want to use another additional EMR, in addition to my existing EMR, another thing to log in and out of and try and reconcile. But if you find it helpful, that's wonderful, especially if it gives you the protocol, the template, the prompts on how to do the H&P, less for you to think about, and making sure that you're checking all the boxes and make sure, things can be on the super bill and coded correctly. That's wonderful.
Well, yeah. So you mentioned the key point, that because it's not geared towards billing, and I used to bill, and I had a different AMR for that, and I no longer bill.
Okay.
So it works for me, but it would not work if you are into billing. That's for
Got
sure.
it. Got it.
Wow. High level stuff across the board. So I'm going to, he's been good all night, so I'm going to unmute Dave Holland to bring us home. But before doing that, I want to thank Martha for being such a great facilitator tonight and for helping to bring this panel together. You're a hero. There's a lot of silent applause, but I'm sure, but it's thundering across New York right now, across this. And I want to thank the panel.
Okay.
You guys are just, as fabulous as advertised, and we're just couldn't be more grateful for giving your time. So that being said, Dave, any last words before we depart?
Yeah, well, I want to thank you all, and I want to particularly thank Martha for putting this together, because we've had a lot of really incredible conversations and panel discussions, but I've learned more here this evening than I think I've learned in 20-something years of dealing with different conversations around medical cannabis. So I am just so excited to know that we bring this kind of talent together, and it can be done regularly. And I think that that's what makes the CIA so different from the other organizations out there right now. So I encourage people to become a member and join committees and start being part of not only the conversation, but suggestions for the policy that should be driving the cannabis industry forward as we look at legalization, particularly in January and thereafter in 2021, because indeed legalization is coming this way. And there's much that has to be done to preserve the medical community, because it is so important, and it shouldn't be subsided by or superseded by an adult use market. And this group of panelists and the level of conversation about the science behind it proves that adult use is an entirely different method and use of the plant. And this still needs to be preserved and promoted, because there's so much to help so many people with it. So thank you all very much for this opportunity. And please become a member, because the more that you do with us, the more we can do to legalize it and create a better policy in New York and the Hudson Valley.
Well, on that note, I just want to thank you all again. Please do jump on our websites, NYCCIA.org or HVCIA.org. Sign up for our newsletter. That doesn't hurt. That's free. Become a member if you'd like to participate at a greater depth, and we welcome all of you. So thank you again. Have a great night, everybody, and we will see you soon.
Thanks, everybody.
Thanks, everybody. See you next time.
Bye.